Hello, I'm Dr. Sarah Smith. This is Step by Step, where we take practitioners through important veterinary conditions and issues step by step. Today, we're talking about what to do when you suspect a snake bite. This algorithm will walk you through history, symptoms, supportive care, and treatment. This algorithm has been peer-reviewed by an emergency critical care faculty at University of Florida, who also happens to be a snake enthusiast. We'll start this algorithm assuming an owner comes in to your hospital and says they suspect their pet had an encounter with a snake. There are two main types of snake envenomations that you will see in the United States. While most of those will be crotolid envenomations, and we will talk primarily about those, I'd like to start with talking about coral snake envenomations. Coral snakes primarily are in the southeastern United States. There are different forms of coral snakes in Texas and Florida. They're typically identified by a black head and black snout with red and black segments separated by yellow. A lot of people have heard the old saying, "Red and yellow will kill a fellow." Well, it turns out that saying isn't always supported by herpetologists that know their snakes, because some coral snakes will not always follow that rule. If there's any doubt, the coral snakes always have a black nose, and if an owner has pictures, you may be able to get a consult with a herpetologist to identify that snake. If an animal is observed with that snake, then you should assume envenomation may have occurred. Signs typically will develop within 18 hours of the envenomation, and once they do begin to occur, they will progress rapidly. If clinical signs are not present, but you have the history that supports they may have been exposed, I recommend transfer to the closest facility with long-term ventilator capability. That's for 24-hour observation in case that patient declines. You could also consider transfer to a facility that has coral snake antivenom available. If a pet presents to you with clinical signs present, I recommend that you perform a triage examination and stabilize the patient depending on what their signs are at that moment. And the signs that develop can be a little bit different depending on cats or dogs. In cats, you may see abnormal PLRs, weakness and ataxia, ascending flaccid paralysis, one of the hallmarks of this. You may also see some cardiovascular and respiratory signs, such as increased respiratory rate, tachycardia, and hypotension. In dogs, signs can look a little bit different, and we tend to see more neurologic and sometimes hematologic signs. Typically, lower motor neuron signs. They may also have flaccid paralysis, dull mentation, hypersalivation, and sometimes vomiting. And an important note is that dogs sometimes have hemolysis, although we do not usually see this in cats. So if you're questioning whether a dog may have been exposed to coral snakes, if you spin down the blood and find it's very hemolyzed, that may support your presumption of snake envenomation. You also can check for echinocytes, as sometimes they will have echinocytes present as well. So if a coral snake encounter was witnessed, the clinical signs are present, and you've stabilized them, I do recommend that you get them to the closest facility with long-term ventilator capability for at least 24-hour observation in case they decline and require that ventilator. Or you may even have to ventilate them until they can get to that facility. And again, if possible, transfer to a location with coral snake antivenom. Now, the coral snake antivenom works best given early on in the onset of symptoms because it will prevent progression but not necessarily reverse symptoms that are already present. And while ventilators sound scary, patients that are envenomated by coral snakes can get off the ventilator and have very normal quality of life, go back to their normal happy selves once the venom is out of their system. So as long as we keep them stable and ventilated through it, they can do okay. And now let's talk more about crotalid envenomations, something more people are probably familiar with because there's so many different types of crotalids or pit vipers throughout the United States. And this term encompasses rattlesnakes, copperheads, cottonmouths, water moccasins. All patients that have potential envenomation will show local puncture wounds where they're bitten, and all of these cause similar clinical signs. Now, if clinical signs are present, oftentimes you'll see painful focal bruising, swelling, or bleeding near the puncture wounds. Patients will often also show signs of systemic effects or shock. If the owner witnessed the snake encounter or they found puncture wounds that could have been from a snake envenomation and no clinical signs are present, we still want to treat this as a potential snake envenomation. I would begin those cases with obtaining some diagnostic testing. Primarily, that's going to be a complete blood count, a chemistry with a CK on that chemistry panel if you have it available, some coagulation testing such as a PT and PTT, and even an in-house blood smear can be very useful in evaluating these patients to see if there was envenomation. If you look at a blood smear of a snake envenomation case, they will often have many echinocytes present. You can also evaluate platelet numbers because platelet counts can be decreased in an envenomation. Other diagnostic abnormalities you may see include azotemia, as well as elevated CK, ALT, and AST. Occasionally you might also see hypokalemia and hyponatremia. Hyperbilirubinemia can occur, especially from hemolysis. And you may see that PT, PTT, and/or an ACT, your coagulation tests, prolonged. If those diagnostic abnormalities are not detected, you want to monitor for at least 8 hours before determining that no envenomation occurred. This may include monitoring the site locally, as well as continuing to monitor those diagnostic tests to ensure the results do not change. Now let's go back up to clinical signs are present. You want to address their pain levels, evaluate their vitals, and start obtaining those same diagnostic tests through blood work. You're going to want to remove anything that could become potentially constricting, like a collar or harness. Also, some owners will have placed a wrap or a tourniquet. Wraps and tourniquets do not actually help in a snake envenomation, and we want to get those off as quickly as possible to help maintain good perfusion to the affected area, as this can really worsen the local effects. You're also going to want to place an IV catheter rapidly, both for IV fluids and for pain medications. While you're starting your supportive care, you're also going to want to monitor their blood pressure and vitals, and ECGs can be helpful as some of these patients will develop arrhythmias. You will want diagnostic testing, CBC, chemistry, coagulation parameters, and blood smear to help guide your therapies as well. And once you have opioid pain medications on board, and this patient is at least a little more comfortable, you can start to analyze the details of the wound. This means you should clip and clean the area surrounding puncture wounds. You also should mark the border of the swelling with a permanent marker and measure the area of most severe swelling and mark level to allow for repeat consistent measurements that can help guide your therapy with objective measurements. If systemic signs develop, or severe pain and swelling occurs at the site, or if your diagnostic tests are abnormal, even if they are not experiencing overt clinical signs, the next step is to begin antivenom treatment. Antivenom is the most important treatment. It is true that reactions can occur, and while you're giving the antivenom, it is important that you monitor your patient as you would for a blood transfusion. But side effects and reactions are relatively rare, and if they have severe signs, this is the best next step for treatment. After antivenom treatment, it is important you continue to monitor. Things to help guide whether you need additional treatment include the swelling, or if pain's not well controlled, even on opioid pain medications. Also, continue to monitor your vital signs, ECG, your blood counts, and coagulation parameters, and continue to monitor renal values, as I have seen patients that have become fairly severely azotemic following envenomations. If your patient is improving over 24 hours and you haven't noticed any regression, their signs, symptoms, and diagnostics continue to improve, that's a sign that that patient is likely stable enough for discharge. If additional treatment is needed based on your monitoring, then you may want to consider repeat Antivenin treatment, continuing IV fluids, and obviously IV pain medications. Depending on blood counts, you may actually require blood product transfusions. I have had to give plasma and packed red blood cells to rare snake envenomations. And something to consider for local effects and swelling is to use a low-level laser therapy. There are some treatments that are not recommended for snake envenomations. We already touched on the tourniquet myth. You do not want to apply a tourniquet to the area of an envenomation. We also really want to avoid non-steroidal anti-inflammatory drugs. We want to avoid steroids, also pre-treating with diphenhydramine. Of course, you may look at using steroids and diphenhydramine if the patient is having a reaction to the antivenin that is given. However, preemptively, that is not recommended. In the early stages, neither antibiotics nor early wound debridement are recommended. These are the local tissue effects from the venom, and antivenom will do more than either of those two treatments. I hope after working through this algorithm, you feel more comfortable and confident next time you encounter something that may be a snake envenomation. Thank you for joining us for this edition of Step by Step.